Now here we'll drop down to the very bottom and the surgical safety statement, which I think we think is a really, really important thing, again, to be put into widespread use in South Carolina. This actually is pretty unique. This kind of phrasing isn't on a lot of checklists around the United States, but everybody on the leadership team in South Carolina thought that this was an important place to take the checklist and for everybody to go. And down the right-hand side, it's got all the different ways that we've seen people change those words. Does anybody have any concerns? Turns into, if you see, suspect, or feel that patient care is compromised, will you speak up? But the spirit of all these different words is the same, that the surgeon is basically, by saying this, is giving permission to everybody in the room to talk if they need to say something, especially if patient safety is being compromised in the room. So, this is another question that you need to ask yourself, particularly if you're going to add things to the checklist. So we talked about some of the things you need to have in your back of your brain if you're going to pull stuff off. These are a list of things that people have added to checklists, and we can probably talk about them one by one. But the question at the top is the one that you really should answer. Is the checklist the best way to take care of this problem? And part of that is you have to think about your own hospital. So, is it the best way to make sure that the patient's hair was removed from the surgical site in the most appropriate way? Is that the best place to actually deal with that? And my guess would be in most places that the best way to deal with changing the hair removal policy is not through the checklist that's actually used once the patient is in the operating room, because most of the time hair removal is performed before the patient actually comes into the operating room. So the checklist might not be the best way to take care of that. It might be in your hospital. Glycemic control. Now this brings up a good point, because where you could easily put a check on that says the glycemic protocol is in place for this patient and it has been filled out. You absolutely could check on that. Or you could put a check that says, check the capillary blood glucose at the beginning of the operation, and you could do that check for every single patient. Both of those things work really well. Just putting the words glycemic control on your checklist probably isn't going to get good glycemic control in place for your patients. So that may not be the best way to do that. Fire risk assessment. Now we've actually, with the emphasis of the Joint Commission on preventing intraoperative fires in recent years, and it's an important thing, a number of hospitals have incorporated fire risk assessments into their checklist. And if you can find an easy way to do that, and you think that's something that should be reviewed before every case that's done in the operating room, this absolutely, it's a safety check that you can absolutely add to your checklist. Just like at the bottom, talking about checking pressure points, every hospital, every anesthesiologist, every nurse that prepares patients for surgery has their own routine for how they check and pad pressure points depending on the case. Putting that check on your checklist in some places can be a good way to actually make sure that that happens for every patient every time. There are other hospitals that wouldn't feel that that was necessary because of their culture or the other processes that they already have in place.